Welcome to this presentation. My name is Nyanchama Julie Nyamao, a Lamra Research Assistant in Kenya. This study was done in Kisii Teaching and Referral Hospital, which is located in Kisii County, and Kisii County is in the western region of Kenya. This was an participatory action research to develop a sustainable package for women with obstetric fistula and stillbirth or early neonatal death. Members of my team include Dr. Sabina Wakasiaka and Jerusha Omari. The main objective for this study was to develop a sustainable support package for women with obstetric fistula and stillbirth that will offer psychosocial support that will be integrated into the current health system in Kenya. The key findings for this study include non-conducive environment for bereaved parents, poor communication and follow-up following obstetric fistula and stillbirth. There was need for capacity building among healthcare providers. There was seclusion and loneliness that is also associated with stigma and rejection. There were misconceptions and beliefs around obstetric fistula and stillbirth. Under non-conducive environment for bereaved parents, we had mixing of women with stillbirth and those who had live babies. There was no private space or room for bereaved parents. There were also no hospital policies and standard operating procedures or support systems for bereaved parents. One of the participants shared the following. There was no privacy except for the curtains that separate them in the ward. This becomes challenging to us counselors when trying to counsel the fistula patients. Such environments do not provide a serene opportunity to carry out efficient counseling. The second key finding was poor communication and lack of follow-up following obstetric fistula and stillbirth. There was a blame game between couples on what had caused the stillbirth or fistula. There was lack of information about obstetric fistula and stillbirth. There was no follow-up following obstetric fistula and stillbirth. There was also lack of compassion from the healthcare providers following obstetric fistula and stillbirth. The third key finding was there was need for capacity building among healthcare providers on the areas of management of labor and management of stillbirth and stillbirth counseling. One of the key participants also shared the following. Some of the people who attend to us in hospital could be trainees, people who attend to women and yet they are not qualified in delivering babies. They need to be supervised by qualified personnel all the time. They should not be left alone with the patients. The fourth key finding was seclusion and loneliness, which is also associated with rejection and stigma. Many women with obstetric fistula and stillbirth had their marriages broken. They were withdrawn from public and social activities. They had low self-esteem, and some of them had depression and suicidal thoughts. One of the women also shared the following. My husband also abandoned me because of the fistula problem. He actually placed me in a public transport vehicle and handed me over to a neighbor who knew my home following discharge from hospital. The last key finding was misconception and beliefs around obstetric fistula and stillbirth. Obstetric fistula and stillbirth is associated with promiscuity. The patriarchal nature of our society and the power of the mother-in-laws has reduced the decision-making power of women. Stillbirth is associated with evil spirits and witchcraft. One of the participants also shared the following. It is said that sometimes evil spirits skip generations, but when they are determined to haunt your family, they do it at their own time. My child was a victim of these evil spirits. The impact of this study. There is increased media engagement and involvement. There is increased male involvement in fistula care. We also have home visiting for women with obstetric fistula. There is also increased interest on obstetric fistula and stillbirth among stakeholders. Thank you. Asanteni sana.